Now, moving forward, I would like to call upon stage our mentors, Dr. Deepak Thorve sir, Dr. Gajanan Chavan sir, and Dr. Anjali Gade ma'am. Next, we will be presenting Dr. Abhijit Nagapurkar sir on transrectal ultrasound guided prostate biopsy.
So, very good afternoon to all the respected delegates and my dear resident friends. Myself, Dr. Abhijit Nagapurkar. I am Associate Professor in Department of Radiology and Interventional Radiology at MGM. Today, I will be talking on transrectal ultrasound guided prostate biopsy. So, in recent time, there is seen significant decline in prostate cancer related mortality due to early prostate cancer detection programs, which includes PSA screening efforts, systematic transrectal ultrasound guided prostate biopsy techniques, and increased public awareness about the prostate cancer. So, TRUS of the prostate was first described by Watanabe in 1968, and TRUS guided systematic sextant biopsy protocol was introduced by Hodge in 1989. So, prostate lies anterior to the rectum, below the bladder, and the apex of the prostate lies on the urogenital diaphragm. Here we can see bladder, the base of the prostate, apex of prostate lying on the urogenital diaphragm. This tortuous structure is a seminal vesicle. The prostate is divided into various zones which actually are not visible sonographically as a distinct entities, but the zones are anterior fibromuscular stroma, then this is the urethra, surrounding the urethra is the periurethral zone, around that is the transitional zone, posterior to this is the central zone where the ejaculatory duct passes and joins the urethra at the verumontanum, and the largest portion of the prostate gland is formed by the peripheral zone. These are the transverse and sagittal images of the prostate. As I said, we cannot distinguish the zones which are described previously, but the largest and slightly echogenic portion is the peripheral zone. Anterior to it is the hypoechoic, slightly hypoechoic transitional zone. Centrally lies the urethra. This hypoechoic line which we can see is the ejaculatory duct. While doing the TRUS, we must look at the seminal vesicles and vasa differentia, which looks like moustache-like structures. Both should be symmetrical. Nearly they are 4.5 to 5.5 centimeter in length and about 2 centimeter in width. They should be smooth, saccular and symmetrical. So, coming to indications for prostate biopsy, diagnosis of a suspected symptomatic prostate cancer patient, that is a patient with bone metastasis and with cord compression like that symptoms. Then prostate nodules or significant asymmetrical prostatic enlargement regardless of PSA levels. PSA levels of more than 4 regardless of any age are the candidates for the prostate biopsy. Men below the age of 60 to 65 with PSA level of more than 2.5 should be considered, and PSA level of more than 0.6 at the age of 40 can be subjected for the or should be taken for the prostate biopsy. In Western countries, screening for prostate cancer in asymptomatic patients with age of more than 50 years is also nowadays in trend, which can be cut down to 45 years if there is strong family history or an African American origin. Contraindications for the prostate biopsy are significant coagulopathy, painful anorectal conditions, severe immunosuppression and acute prostatitis. So, before going to the procedure, there should be written informed consent should be taken. All anticoagulant therapy should be stopped at least 7 days before the procedure, and INR should be below 1.5. Antibiotic prophylaxis, as all said in last topics discussions, fluoroquinolone is preferred as it has wide spectrum for the E. coli management, which should be given orally at least 1 hour before the procedure and followed by OD dose for consecutive 3 days is the regime. Now there is much debate about enema should be given or not, but it is better to give enema as it decreases the amount of feces in the rectum, thereby producing the superior acoustic window for the prostate imaging and may reduce the bacterial seeding to the prostate. For the biopsy, analgesia is a very important thing which should be dealt with. Most commonly, topical lidocaine jelly is used per rectally. While applying abundant of lignocaine jelly, you cover up with your digital examination also. We as radiologists are not as good as you urologist people in examination, but by the time you come to know whether it is nodular or hard or firm, like that. Then we can give nerve blocks also, wherein we can instill 1% of lidocaine, about 10 ml, around the prostate 10 to 15 minutes before the procedure, so that it will act and give the nerve block. Then direct infiltration into the prostate is also one of the option, but it is not as good. Then if we are planning for the transperineal biopsy, skin and subcutaneous infiltration of the contrast along with deep sedation will be required, as it is very much painful procedure. Now coming to patient position, patient lies in left lateral decubitus position with knee and hip flexed in 90 degrees. So before starting the procedure, the area or perianal area, perineal area and adjacent buttocks are painted with betadine, thoroughly cleaned. Here we can see the truss probe, which is having probe cover with lignocaine jelly, and before introduction also we apply abundant of lignocaine over the probe as a coupling agent, and it acts as a both local and coupling agent. So technique of prostate biopsy, we must assess the prostate volume, then screen the prostate in transverse and sagittal planes from base to apex. Then we should note the location and characteristics of lesion, if any, we found on the ultrasound, like its echogenicity, if there are calcifications or not, contour abnormalities, any cystic structures are there or not. Then we use 18 gauge automatic or spring driven core biopsy gun, which passes through the needle guide attached to the ultrasound probe. The biopsy gun has a throw of about 20 to 22 mm, and in that we get the sample of 1.5 centimeter of tissue, and the tip extends beyond 0.5 centimeter beyond the area which is sampled. Hence the localization of loaded gun tip is very crucial. We should be the lesion should be kept in the range of 2 to 2.5 centimeter ahead of the unfired gun tip. This is the barred automatic biopsy gun. Here is the slot of the where the tissue gets collected, and this is the 0.5 centimeter of the dead portion of the needle, which goes ahead of the lesion. Now coming to truss biopsy schemes, sextant biopsy scheme, which includes one core bilaterally, each from base, mid and apex of the gland. the samples includes both peripheral zone and transition zone. The vast majority of the adenocarcinoma are located posterolaterally in peripheral zone. Various other schemes are also reported. The primary is the sextant biopsy scheme, which was introduced by Hodge in 1989. Then comes the 10-core biopsy of Presti, introduced in 2000. Then comes 12-core or the double sextant biopsy, 13-core or 5-region biopsy technique. Some other protocols are also there, like 5 region, 6, 8 biopsy, then 11-core biopsy, and some of the literature also tells about the 32-core biopsies of the prostate. So coming to important part, post biopsy sample collection. So proper sampling and labeling is very important. Sample should be collected in 10% formalin solution, preferably each sample in separate bottle. But usual trend is 2 bottles, one for right and one for left is practiced. But due to some lookalike cancers like Cooper's gland at the apex and seminal vesicle at the base, some pathologists prefer to label each sample with their location. So risk and complications of the prostate biopsy. Immediate complication we can see are hematuria, vasovagal episodes, rectal bleeding, urinary retention. Persistent hematuria may last for few days, but the counseling of patient is very important in this case. We must tell the patient to remain well hydrated and don't worry about the hematuria part. Then vague pelvic discomfort may last for few days, dysuria. Hematospermia, though clinically insignificant, but may last for many weeks, and post-biopsy infections are encountered. So take-home message will be only digital examination or TRUS or PSA alone cannot diagnose the prostate cancer without a tissue biopsy. And hypoechoic foci seen on grayscale TRUS should be considered as adenocarcinoma and included in the biopsy specimens. Now, the recent studies say TRUS guided biopsy is also a blind procedure. Fusion imaging guided biopsy is the upcoming trend. The multimodality MRI of the prostate should be done, that should be fused with the USG, and then precise biopsy should be done. So thank you. Sir, may I take 1 minute? Advertising myself, sir. No, advertising myself. Sir, other IR procedures related to urology, vascular procedures like prostatic artery embolization in BPH can be done in patients with moderate to severe LUTS patients with no improvement or intolerant to the medical management, or those patients which are not willing for the surgical management. Then other conditions like renal artery stentings for pseudoaneurysms, aneurysms, stenosis, then embolization of the aneurysm, pseudoaneurysms in case of hematuria. Then renal thrombectomy and thrombolysis are also in the field, though these are done in the cath lab setup only, a relatively cumbersome job, but we can go through this as these are minimally invasive procedures. Non-vascular part we can do HIFU, laser or thermal ablations of the prostatic nodules or lesions, then PCN catheterizations in obstructive uropathy or pyonephrosis, peripheral abscess drainages, perinephric, drain placements in the perinephric areas, then post-renal injury, perinephric hematoma, as Shana madam told us, the large hematomas displacing the kidneys and all, we can manage them with only ultrasound guidance. Thank you so much.
For next session, I would like to invite Dr. Nikita Mantri to present on imaging in urolithiasis. The moderators will be Dr. Atul Soni sir, Dr. Priyanka Pansambar ma'am, Dr. Preeti Khataukar ma'am.
Very good afternoon, everyone. Today I'll be giving some key insights on imaging in urolithiasis. So coming to types of renal stones, it is very important for us to know types of renal stones because that leads us to the composition of renal stones which have different imaging features and that guides us to the management. Management of renal stones depends upon the density of stone, the type of stone, the composition, size and location. So about 80% of the renal stones are calcium based. Most hardest of all is bruchite, which is approximately 1700 to 2800 HU value on NCCT. Uric acid is the radiolucent stone which is very difficult to detect on plain imaging. Hence we prefer to go for excretory urography. Struvite is an important stone as it is formed due to renal infection. It also has a higher HU value. So these are the major renal stones as we have seen. Next is a staghorn calculus. This is a large pelvic calculus in this image which is extending to the callicial system. As it represents the stag's antler, it is termed as staghorn calculus. It has a laminated appearance and needs to be treated surgically. Now why is it important to treat it surgically is because even leaving behind a small fragment of it can act as reservoir of infection and result in recurrent stone formation. Here in this radiograph we see a oblong shaped radiopacity at L4 vertebral level on left side. Now we can often get confused whether it is a vascular calcification or whether it is a ureteric stone. So we need to go for further excretory urographic imaging and ultrasonography for evaluation. This image shows a large calculus which has spiculated margins. It is a rare form of jackstone calculus. So this is a jackstone calculus. It is easily susceptible to fragmentation. Coming to the lower down image, we can often get confused whether it is a gallbladder stone or a renal cal. So let me tell you that usually 10 to 15% of gallbladder stones are radio-opaque. They are more often rounded in nature and are clustered together unlike renal calculus. One thing we can do here is take a posterior-anterior or antero-posterior radiograph. As we know, more is the distance of the image, more is the distance of foreign object that we are imaging from the film, more is its size. So when we image gallbladder stone on an AP radiograph, it will appear considerably larger in size. So that's how we can differentiate. But anyways, we go for further imaging with other excretory urography and NCCT. So this is intravenous pylography. Intravenous pylography is important in sense that it not only gives us an advent of renal anatomy, but also an account of renal function. Disadvantages not used in patients with renal insufficiency. Now it is majorly replaced by excretory urography. So here we see contrast within the callicial system down into the ureters. Alongside we also see dilated ectatic collecting tubules here which consists of contrast. So this gives an appearance of paintbrush or bouquet of flower appearance. This is seen in medullary sponge kidney. Now why it is important is because these ectatic collecting tubules can often result in stusses of urine and that can result in urinary stone formation. About 80% of medullary sponge kidneys are associated with medullary nephrocalcinosis. USG is frequently the first line of investigation, but it has only 24% sensitivity. We often mention in the report the stone obscured due to bowel gases. It is due to it also depends on the body habitus and overlying bowel gas. Hence, we do not go for it for particular detection of ureteric calculi. But however, it is used in pregnant patients, pediatric patients, and ones with recurrent bouts of urolithiasis. Apart from this, detection of hydronephrosis, the extent of it, presence of echos, and especially useful in detection of VUJ calculus. So here, there are some signs we can see. This is echogenic stone and giving a posterior acoustic shadowing. On color Doppler study, there's a focus of turbulent flow giving a twinkling artifact. So there, in this image, we see absence of ureteric jet. This indicates some kind of obstruction up there. Also, we can calculate the PSV of this ureteric jet, which if less than 20 centimeter per second gives us an account of this, some kind of partial obstructive uropathy. NCCT is the most sensitive modality. It can detect even the tiniest calculus. However, radiolucent stones cannot be detected, and you need to take into account the history of the patient as well. One disadvantage that is major is about radiation exposure. Here in this image, we see tiny specks of calcific foci in the medullary region. These are nothing but Randall's plaque. It is milder form of medullary nephrocalcinosis. Here we see image with generalized calcification in the medullary pyramids. This is seen most commonly associated with metabolic conditions like hyperparathyroidism. The patient can be asymptomatic or present with some kind of urinary colic. In this image, what we find is a small shrunken kidney. It has a large ground glass-like calcification with paper thinning of cortex. So this kind of imaging, one should go for putty kidney, that is end-stage renal TB. Here, what we see is a large bulky kidney. There's a contracted pelvis with staghorn calculus within it and a dilated calycial system giving a multiloculated appearance that resembles paws of bear. So one important sign here is the bear paw sign, gives us xanthogranulomatous pyelonephritis. Why it is important to note is no conservative or medical therapy exists, and surgical nephrectomy is the only curative thing. One major differentiation we must know is phleboliths and ureteral calcification. So here we see a calcification right adjacent to the VUJ. But alongside there's a soft tissue halo around the calculus which gives a soft tissue rim sign. This is more in favor of ureteric calculi, about 80% sensitive and 100% specific. Comet tail sign, this is eccentric soft tissue seen around the calculi here, but this is more in favor of phleboliths. Stone burden and stone fragility. Assessment of stone burden and fragility is of paramount importance in urolithiasis, but make sure you do it in bone window settings as it gives an accurate estimate. When you see volume of stone being more than 700 mm cube, it is the predictor of lithotripsy failure. Stone fragility is the internal structure of stone. Here we see some kind of inhomogeneities in the form of low attenuation areas. Now why is this important is heterogeneous stones with low attenuation areas are more susceptible to fragmentation in contrast to those who have homogeneous appearance, and they are usually harder to break, which requires more treatment sessions. Skin to surface distance. We take it usually in 3 dimensions, 0, 45 and 90 degree. Then you calculate a mean SSD. When we get it above 10 centimeters, then one must think that there's failure to achieve stone-free status after SWL. Thus, then you can go for ureteroscopic intervention or PCNL for stones that are greater than 10 centimeter from skin. Dual energy CT, it is a newer modality, and why is it important is to differentiate basically uric acid stones from the non-uric acid stone. 2 X-ray attenuation values are used, 80 and 140. The difference in chemical composition accounts for this difference. So the voxels that are coded in blue have signal behavior similar to that of calcium, and those that are coded in red have behavior similar to that of uric acid. So hence they can be easily differentiated. This is important because uric acid stones can be treated primarily with urinary alkalinization and surgical therapy being reserved only for the non-responsive patients. Management. In short, there's a chart here of management. Less than 1 centimeter, no symptoms, you go for observation. If less than 1 centimeter and the patient is symptomatic, then you go for either ESWL or ureteroscopy. That depends upon the composition and the size further. And 1 to 2 centimeter is you go for ESWL or PCNL. But more than 2 centimeter, as said previous also, staghorn calculus, you go for PCNL, as removing the entire stone is very essential. Similar goes with the ureteric stones. In ureteric stones, smaller size, we go for medical expulsive therapy. And if it is more than 10 centimeter, then you will go for SWL or ureteroscopy. One thing is that ESWL has a rare complication of Steinstrass. What is Steinstrass? It is a German word for stone street. So here there is a pileup of stones in distal ureter which can further cause ureteric obstruction. So whenever you report NCCT, also take into account the treatment history of the patient. In PCNL, you remove the entire stone through skin when they cannot pass on their own. Radiation dose is one of the key concerns that comes along with NCCT. Some of the strategies I would suggest for dose reduction include use of restricting scanning range from the top of kidneys to the base of bladder, which we further can reduce by using of 5 mm thick sections instead of the routine 1 mm sections. That is reducing radiation dose to 30 to 50%. Also, automatic tube current and potential modulation can be used alongside elevating noise index is one such measure. So coming to few interesting cases. First case, there was a hypertensive diabetic patient with repeated spikes of fever and flank pain. Here we see mottled gas appearance in renal fossa, which is further extending down into the renal pelvis. On NCCT, we notice a large staghorn calculus with multiple air foci in the renal parenchyma and also in the paracolic gutter extending down into the anterior abdominal wall as well. Now, it is important to know emphysematous pyelonephritis, which is a very morbid condition, and about 90% cases are seen in diabetics. On NCCT, it is important to note the grading of emphysematous pyelonephritis, because treatment in milder cases is usually with IV antibiotics, while percutaneous drainage can be performed and severe cases may warrant nephrectomy. So case 2, this was very interesting case. A 50-year-old female diabetic came to our department with history of recurrent urinary tract infection. She had urgency and frequency of micturition. So what we were suspecting is pyelonephritis. In this image on USG, we see hydronephrosis on both sides. Along with it, there's echogenic content at the callicial apex and also at the VUJ. On further imaging with excretory urography, we have this excavation of the contrast around the callicial, out of the callicial system around the papillary segments. Now this is giving a lobster claw sign. Further on axial imaging, contrast in bilateral renal callaceous is surrounding the papillary segments. Here you can see this thin line. So that gives a signet ring appearance. Sloughed off papilla at the VUJ, obstruction with upstream dilatation of callicial system. So concised findings: diabetic patient suspected pyelonephritis, mild hydronephrosis, echos, and non-enhancing filling defects, streaking of contrast in excavated papillary region. The diagnosis of renal papillary necrosis was made. So why is it important? Because it is commonly, if treated early, it can minimize the decline in renal function seen bilaterally, and most common age of presentation is 40 years, seen in diabetic patient, as was in our case. Another case is 40 years old female with epigastric and left lumbar pain. She was having fever with chills, also a diabetic patient. With this gas in the renal fossa, why I had taken the case was there was a calcula which was suspected to be in the ureter. But on excretory urography, what we found was this calculi lying outside the ureter, giving us that it was not a ureteric calculi, but rather a phlebolith. So diagnosis with excretory urography is of immense importance. Take-home message will be multi-detector CT plays an important role in management of urolithiasis and also follow-up of the patient. And recent technological developments will help radiologists to meet the growing demands and expectations of urologists. And in addition, also it's prudent to be aware of radiation risk and take appropriate measures to minimize this risk and optimize the image quality as well. Thank you.
Now I would like to call upon stage Dr. Prashant Darak sir to have a talk on this topic.
It was a nice presentation by Nikita, Dr. Nikita. From urologist perspective, I would like to distill for urolithiasis. These are the following investigations we would like to do for detection and for the management of the stone disease. That is, one is sonography, X-ray, NCCT, conventional IVU and CT IVU. We will go one by one. I have termed USG KU-BU because we want urethra also to be included when we do this sonography. So it should be kidney, urethra, bladder and urethra. These are a few images of sonography. Normal looking kidney, hydronephrotic kidney. This is how calculi looks, hydronephrosis and parenchymal thinning. So it is like a urologist stethoscope because it is an extended clinical examination for urologist. So what we want from a from a good sonography, that size of the both kidneys should be mentioned, then parenchymal thickness should be mentioned, corticomedullary differentiation, then stone should be identified, then size and number and exact location. I will come to the exact location in another slide, but exact location should be mentioned properly. Then obstruction assessment, the degree of obstruction and the level of obstruction, its impact on the renal function is also should be well mentioned. Then hydronephrosis detection, again stone with hydronephrosis and stone without hydronephrosis, definitely to some extent management changes. Stone without hydronephrosis are difficult to treat. Stone with hydronephrosis can be easily surgically dealt with. Then degree of internal echoes. It is important to know internal echoes because if there is an infection, then the management changes. We might have to do a DJ stenting or a PCM to drain the obstruction before going for a management of the stone. Then differentiation between the parenchymal and luminal calcification should be made properly. Then coming to the bladder calculi should be, sonography for bladder calculi should be done in a static as well as dynamic, both ways, so that bladder calculi is properly diagnosed. Then evaluation of the proximal urethra for the stone should be done. Sometimes a prostatic urethral calculus is missed and the whole scenario changes on the on table. Then points to be considered is like post-void residue, full bladder and post-void residue should be mentioned in each case. That has been already mentioned. So any other differential diagnosis, if they find on the sonography like renal cyst, tumor, that should be mentioned. Renal cyst, if it is there, then it is important for us to know and characterize them on further CT scan or something to for the next procedure like PCNL or PCNL. Then complication like inflammation, infection, which I already mentioned, that should be proper, if it is visible, it should be mentioned. And good communication between urologist and radiologist should be there whenever there is a doubt in the given case. So coming to this exact location, I would like to stress upon a point that in urology we expect from PUJ to upper sacroiliac joint is considered as upper ureter, and then upper sacroiliac joint to inferior sacroiliac joint is considered as mid ureter, and below that it is lower ureter. So if possible, sonography should mention according to this classification, so that it becomes easy for us to decide and counsel the patient for the management. Because upper ureteric stone might require additional procedure other than only ureteroscopy. Mid ureter and lower ureter can be managed with the ureteroscopy procedure. So this has to be mentioned properly. Then X-ray KU view, again just passing comment, because it should be a well prepared X-ray, bony landmark should be seen. Any associated abnormalities, then presence of 12th rib, of course it should be mentioned, because PCNL or rib cutting incision for any procedure, we need to know this information, and density of the stone can be judged, right? So coming to NCCT, From NCCT, we need to know accurate identification, size, location, number, stone burden, composition if possible, and most importantly, Hounsfield unit. Hounsfield unit can decide our treatment protocol, and Hounsfield unit and location of the stone and size of the stone, these are all factors, they are important in deciding the management of the stone disease. So, next is obstruction assessment. Degree and location of the obstruction should be mentioned. Then shortest possible distance, which has already been covered. Shortest possible distance from the skin to stone distance should be mentioned to decide the treatment. Then hydronephrosis, I have already mentioned in USG. Differentiation between parenchymal and intraluminal calcification. Then CT scan should give us better idea about this abnormal position of the kidney and or any malrotation if it is there, like pelvic kidney or ectopic kidney, horseshoe kidney, to decide upon the plan of the treatment. Then assessment of the ureter. This is one of the reconstructed image of the ureter. This kind of an image will really help us in managing the stone disease. If it is possible, this kind of images we need. Then radiolation stones can be visualized in CT. Then coming to tissue assessment, that perinephric fat standing or periureteric fat standing should be mentioned. That is any signs of inflammation, infection or other associated abnormalities that can change our management. Then cortical thickness. Important point again comes with retrorenal colon. As we can see here, retrorenal colon can be seen, and it should, whenever it is present, though the incidence is very less, whenever it is present, it should be mentioned in the report, because this is the site from where we go for puncture, PCNL, and whenever there is a retrorenal colon, there is a high chance of injury to the colon while during our surgery. Then any other alternative diagnosis, if it is there, that should be mentioned. Renal cyst has to be properly mentioned, because again, puncture, we do a puncture from skin to cortex, so cyst come in between our puncture, so that has to be properly mentioned. Again, one more point I just wanted to differ, that Dr. Nikita said 5 mm cuts should be there. I think it should be 2 mm cut, because in 5 mm cuts we can definitely miss a small stone. Then communicating again with the urologist is important. Conventional IVU, I will not go in detail. It is special X-ray which was done earlier, and nowadays CT IVU is gold standard. This is a procedure, and this is how the conventional IVU looks. But coming to CT IVU, why CT IVU? Because it gives an anatomical roadmap, a clear outline of the urinary system for us to manage the patients. Then congenital anomalies, if it is present, it can be easily noted. Demonstration of the renal function is important, and of course at the same time function of the opposite kidney can be seen. Any feeling defect can be confirmed out on its nature, and then there should be a comment about anterior calaceal and posterior calaceal stones. Then obstruction assessment, tissue differentiation, that is clear visualization and differentiation of renal parenchyma, collecting system and other structures to assess in relation to the stone. It should be clearly done. Then infundibulum, whether infundibulum is long, narrow, short or wide should be mentioned. A 3D reconstructive image can really help us. In this image, if the contrast color is faded and then stone is made more brighter, then we can have a better picture of pelvic calaceal anatomy with the stone, in relation to the stone, where exactly is the stone. In some cases like cases like anomalous kidneys, like pelvic kidney or pelvic kidney, ectopic kidneys, horseshoe kidneys, vascular evaluation should be done even without asking, because in surgical planning we need to know the vessels around the kidney. Then just an example of this is a 3D video. नहीं वीडियो बहुत नहीं त्याच्यात पण आहे त्याच्यातून डायरेक्ट पण दाखवू शकतो. See, we can see this beautiful 3D reconstructed video. These kind of images can help us, because see, stone here we can see the stone is more extending into the calyces, which was not seen from the front view. This is a similar same patient. This kind of images can really help us during the management of the stone disease. So, by fulfilling these expectations, radiologists can really play a crucial role in accurately diagnosing in urolithiasis and allowing us to manage these patients. Thank you.
Yeah, both the speakers have given good presentations. We are open for any questions or comments from the house.
Sir, are we supposed to mention volume of each and every calculus we see?
Yes.
In such cases, it becomes difficult for us to mention the volume.
2 mm.
The volume of calculus of each and every, like as we see, has to be mentioned on the report.
If it is possible, it should be mentioned. Not for the 2-3 mm. We are talking about large stones. The large stones should be mentioned. What is the volume?
Actually, smaller stones you can just give the size. For larger stones, we need volume.
Any size criteria for the volume to be mentioned? Like
there is
till
no
what
such criteria, but I mean, volume can decide the treatment. We can counsel the patient whether you will require 1 setting, you will require 2 settings.
Okay.
For the stone removal. Volume will decide. I mean, we will be in a better position to tell them whether we will be able to remove all the stone in one single surgery or not.
Okay.
Yes.
Okay. What additional information you also want from us when you say that whether there are any stones along the DJ's?
Yes. Whenever there is a DJ stent, if there is any stone, it should be mentioned, so that before removing the DJ stent, we can counsel them regarding a ureteroscopy procedure for the stone removal. Yeah.
Thank you.
Thank you so much to all the moderators.
On the remaining lecture after a transplant surgery by a urologist, radiologist, this lecture is being done.
Okay. I'm extremely sorry for the problem which I had. So I will not take more than 6 or 7 minutes at the most. You can time me, there is no problem, I can stop. So I am going to speak on cross-guided biopsy, urologist's perspective. More than urologist's perspective, I am going to speak something which will help all the urologists and radiologists performing cross-guided biopsy. Plus, it will also should motivate radiologists who are not doing it, and they should start doing cross-guided biopsies. So, Biopsy, as you all know, we do for PSA more than 10 nanogram per ml. If it is between 4 to 10, we decide upon certain other factors, but you need not know that because we are going to refer the patients to you. But the first sentence is most important. Suspicious DRE with normal PSA. That is the most important indication. So I would suggest that radiologists who are doing transrectal guided biopsy should put a finger in rectum and try to feel the prostate before they perform guided biopsies. There are certain indications for repeat biopsy. Actually, the urologist should know all this. When the initial biopsy is negative for some reasons, these are the points to be considered prior to advising a repeat biopsy. Now, when you prepare the patient, you should stop herbal medicines. That is very important because many herbal medicines have a blood thinning effect in them. So most of the radiologists don't know if they are taking some herbal medicines for prostate enlarged prostate and prostatic symptoms. You should take a proper history and stop all herbal medicines because it will bleed. Aspirin to be stopped 3 days prior to biopsy. If he is on clopidogrel, it should be at least 5 to 7 days. If he is on latest blood thinners like rivaroxaban, you can stop it, but there is a risk of leading to stroke. You should know this when you tell the patient to stop this drug. INR should be normal if these patients are already on the drug. Antibiotic prophylaxis is must, but the most important thing is never ever give enema prior to biopsy. You should never give enema or suggest the patient because his normal bowel habits are okay to evacuate the bowel. If you give enema, what will happen is lot of fecal matter will come and get accumulated into the rectum and in the distal colon. And this can lead to infection. So never ever advise an enema prior to biopsy. Remember this whenever you are going to do a prostate biopsy. Now the biggest question is how many cores? So we are unhappy if you give less cores, and sometimes urologists expect more cores to be taken. But remember, this was the study way back more than 15 years back which has cleared this dilemma of how many cores to be taken, and it should be minimum 10 cores and maximum or ideal should be 12 core biopsy. If you give anything less than 10 cores, it is not good, and all the cores should be laterally directed. This is very important. All the cores which you are taking from the prostate should be laterally directed, and these two factors if you follow, it increases significantly the cancer detection rate and also reduces the adverse events. So 12 core biopsy, this is just an example of transrectal biopsy. I am doing this biopsy, you can see the urethra, the bladder, and maximum concentration is on the lateral aspect of the prostate. So if you keep more of lateral aspect of the prostate on the screen, automatically all your biopsies will be laterally targeted biopsies, and definitely the yield will be more when you have a laterally targeted biopsy. Yield means we want more of cancer detection rather than just giving a good sample for biopsy. So keep the urethra and the bladder more medially, get maximum amount of prostate on the screen, and then do biopsy. You will perfectly hit the area which the urologist want. So pathology specimen 12 core. If needed a target biopsy, if there is an hypoechoic area, you can target that. The core thickness should be checked, and all cores should be labeled packed and labeled separately. This is very important because you should have 12 bottles before you start a biopsy, because we want to know which core is positive from the pathologist. We want to know how many cores are positive after the biopsy. So all this matters in a great way to the urologist to define or to make a decision prior to subjecting this patient for surgical management. So 12 bottles, each core to be put separately in one bottle. This is mandatory before you do a prostate biopsy. There are some complications like bleeding. I was actually not going to talk, but Dr. Vare told me that you have to tell something about the complications. So if there is a minor bleeding, you can just have some tamponade, put your finger in the rectum, press against the prostate for 5 minutes or 10 minutes. You can just ask your assistant or your technician to do it. It will definitely stop. It doesn't bleed much. If it doesn't stop, then you can put some tamponade, some balloon. You can take a K90 catheter or any catheter which is available. Put a glove finger glove and just inflate and keep it there for 15 minutes. A simple procedure you can do in your clinic. This will stop. If it is major bleeding, then it might require angioembolization, but rarely it happens. If you are exactly targeting the needle in the prostate, it will rarely bleed. There are some other complications like retention of urine, vasovagal attack if the patient is not come with full stomach or hematospermia. Well, these are all manageable. But the most important worrisome complication of transrectal prostate biopsy is infection. The coliform bacteria which are there in the rectum will all enter into the prostate with each passage of needle from the rectum in the prostate. So this is what happens when we do a transrectal biopsy, and this is the most worrisome complication, because if you see the risk is low, 5 to 7%, but 2 to 4% hospital admissions, many emergency visits, and it increases the cost to the patient. And because of this, friends, now we are talking on trans-guided prostate biopsy, but soon, or I would say this is an outdated procedure. We should not do transrectal prostate biopsy. We should stop it as early as possible, and what we should now focus is on transperineal prostate biopsy. This is the future, and I am not saying it. All the latest guidelines which have come, European Urology Association, American Urology Association, everyone is very, very clearly stated that you have to prefer transperineal prostate biopsy over transrectal biopsy. So we have to shift to that. We have recently shifted. Unfortunately, we have just started doing, so I don't have a good video, but I am taking help of animations at how you should do it. So this is what you introduce the probe. This is the what you see on the right side of the screen is the VAS score, that is the visual analog pain score, which is less. You give local anesthesia. This is under local anesthesia. You give local anesthesia to the skin first, and then you give periprostatic block with a spinal needle. You take a 23 gauge long spinal needle, and you can just give a periprostatic block so that both the sides of the prostate on the right lobe and the left lobe can get blocked. And then you place a 16 gauge or a 14 gauge needle, and through that you introduce your biopsy gun. Okay. So when you do this, this is done transperineally, so less chances of infection. No coliform bacteria will enter the prostate through the rectum. This is a fairly I will not say a simple procedure, but once you start doing more biopsies, you will get used to all these transperineal biopsies. So this is the periprostatic block which is given. You can just go through the animation. This is a large 4 needle, 14 gauge or 16 gauge needle, which is passed on both the sides. You initially mark. You can already see the markings on this left side of the image. And then put the biopsy gun through the needle and take multiple biopsies, directed the same way as we were doing with the transrectal biopsies. This is the routine barred needle, routine transrectal biopsy needle which we are using, which will go through the 14 gauge needle, and then it is directed at all the targeted sites where we want to, from where we want to take the biopsy. This is what is done. This is how it looks. Okay, so the chances of infection with transperineal biopsy are significantly less as compared to transrectal biopsy. So EUA guidelines has some specific very good practical points which you should know. Transperineal biopsy is always preferred over transrectal biopsy. If you are doing a transperineal biopsy, you clean the skin, perineal skin properly with betadine. If you are doing a transrectal biopsy, you have to inject povidone iodine into the rectum. That also reduces the colonization of the bacteria. Do not use fluoroquinolones. Fluoroquinolones are contraindicated in transrectal biopsy. If you want to use, you can use cephalosporins, you can use amoxiclavulinic acid, or you can use other antibiotics like fosfomycin, but do not use fluoroquinolones, and ensure that the biopsy is taken from all the parts of the prostate and processing is done separately. So this is a short table how the biopsy done by radiologist or urologist will help the management of the patient. If it is localized, we want three things. We want the diagnosis, we want the Gleason score, we want the Gleason score. If it is locally advanced, then the prostate biopsy will tell us whether there is a prostatic vessel involvement or periprostatic nerve involvement. That is important. And if it is advanced, we just want a diagnosis, then we are not worried about the periprostatic involvement or whether there is any involvement or the Gleason score of the prostate. So that because the management of advanced CA prostate is entirely different, it requires only the diagnosis of the CA prostate. Thank you.
Thank you, Abhay.
Any questions?
Yeah, any comments?
The prostate size is small, like say 15 or 20 grams only, and if the PSA is high, still you want 12.
No.
Yes.
No. See, whenever the prostatic volume is more than 40 grams, the intravesical medullary protrusion volume is more than 25, it has to be saturation biopsy. There is no other alternative as far as the literature is concerned. Saturation biopsy means 24 cores. And nowadays, most of the people they have stated is that don't rely on only xylocaine gel as far as the anesthetic agent is concerned in case of prostatic fossa. All the biopsies has to be done with periprostatic blocks. It's very simple thing. It can be given bibasilar and apical view. So whenever the prostatic biopsies they are missed, they are always from the apices and the anterior part of the prostate, where the pain is more and the bleeding is more. So we are likely to be more tentative while taking biopsies from the apex and anterior part. So when you give block, the acceptance by the patient is very high, and you can take 24 cores very easily. So it entirely depends upon, and when there is a
12 course, not 24.
24 in selective case, that's what I am saying. See, if there is a previously negative biopsy and there is a persistently rise in the PSA levels, then it has to be saturation biopsy. There is no alternative. I mean, in all those individuals, it has to be saturation.
Most of the times, about 95% of the times, 12 core biopsies are enough. Even if the prostate is small, you can easily take 10 to 12 cores. There is absolutely no problem. You have to keep the needle slightly outside the capsule, so that when there is a throw of the needle, it should not go beyond the prostate. So that precaution, if you take in smaller prostate, what happens that if it is a very small prostate, you are keeping the needle here, it will go beyond the prostate and hit the periprostatic vessels, the arteries of the nerve. So small prostate, you keep the needle away from the prostate and hit from here, so that it will stay in the prostate gland or at the capsule. It will not go beyond the capsule. Large prostate, it doesn't matter much. Even if you are at the capsule, the prostate is so huge that the needle will be always in the prostate and will not go beyond the prostatic capsule.
Again,
so if that small precaution, if you take, it will not be hit.
In case of known case of CAP and already treated, then also on few instances probably biopsies they are asked. In those all individuals also you need to take more cores. I mean, you cannot take limited 6 core biopsy. 6-10 biopsy is outdated. I mean, beyond doubt, there is nothing called 6-10 biopsy now.
Thank you. Yes.
Aspects. And another most important thing is that we always make a protocol. We admit the patient prior day, we give the IV fluids, we give the IV antibiotics, we give the laxative, we see that his rectum is empty, morning antibiotic, and then we did the transrectal ultrasound. If needed, patient if he is having catheter, we can pull the catheter and we can get good guidance around it. So these are all the plus point while doing the lithotomy position. And many time in lateral position, patient's cooperation is many time not, old patients are there. So that is what we come across while we are doing more cases. We must have done more than 50, and this lithotomy position we find it very comfortable.
Yes. Sir, IV antibiotic is not indicated at all. You can give oral antibiotic, there is absolutely no problem.
Yeah.
If the patient
And
has any post biopsy infection or sepsis, you can start him on IV antibiotics. Enema is strictly.
no, we are not given enema, we just give laxative. And none of patient has got infection.
Now we'll have to shift to transperineal biopsy.
Yes.
Transrectal biopsies, everyone should stop. We have to shift to transperineal biopsy. You were not there for the lecture, you were talking with your girlfriend also. How you come to know?
नाही नाही एखादं होतं काय काय ट्रान्सलेटर
Yeah, so there is a study, there are a lot of studies on this thing that fluoroquinolone has a lot of resistance to the coliform organisms. Fluoroquinolone is good for gram-negative organisms, but it has got a lot of resistance, and if you use that, then your resistance pattern will increase. When you have a UTI, urinary infection, that will not work. So that's why they say that you don't use fluoroquinolones when you are doing a prostate biopsy. Try to use other antibiotics if required. Whenever you have an urinary infection associated with it, will work. Yes. Yes. MR fusion is, yeah, it is but it is not available at so many places. Hardly at a few centers it is available.
Centers in the country.
Less than. So MRI fusion is difficult.
No, actually MRI images on the ultrasound, you can feed the image ultrasound and then it can be done.
Basic intention is to find out the CAP which are in the hidden areas, number one. And the negative prostatic biopsy, which in fact having a CAP, should be diagnosed. That is the two intention. Now recently after 2017, with the prostatic elastography, we can take, like we laterally directed 12 cores is the standard way in which we do it. But if you have a elastography area which is loss of elasticity plus which falls into violet and red kind of area on elastography on STE, from that area if we can take additional 2 cores, then definitely your efficacy in diagnosing CAP is more. So prostatic elastography as a technique to take more cores from apart from 12 core would probably definitely help in due course.
Yes, sir. No, it is not mandatory to put a Foley's catheter prior to transrectal biopsy. It is absolutely not needed. Okay? So remember this, if the patient has post-biopsy retention which can occur because of prostatic congestion, prostatic infarcts, pain, then you can put a Foley's for a few days and then remove it. But before biopsy, there is absolutely no indication to put a Foley's catheter prior to transrectal biopsy.
With PMSA scan, you can localize the lesion very well and you can do only that lesion biopsy.
No. See, laterally targeted by all the CA prostate will start from peripheral zone. It's very clear. There will be no prostatic cancer which will start from the transitional zone or from the central zone. If you are targeting the lateral part of the prostate, automatically you are in the peripheral zone and your yield of cancer detection is going to increase. Now, if you see a small hypoechoic lesion in the transitional zone, the chances of that hypoechoic lesion being malignancy is almost to the tune of only 20 to 25%. Only 20 to 25%. So even if you miss or don't take a biopsy from that hypoechoic lesion which is in the transitional zone or in the central zone, it's not going to matter much. The cancer prostate will start in the peripheral zone and then it will invade the transitional zone. So the initiation of the cancer is from the peripheral zone. So any laterally targeted biopsies is 100% is going to give you good yield rather than going to only to the targeted lesions. That if you are feeling that those are cancer, but only 25% of those, 75% of those lesions hypoechoic are benign. So you are not gaining much by targeting such lesions of the prostate.
Abhay sir, one last question. During procedure, how do you confirm that you hit the prostate? After taking the specimen, what are the things you look for that the tissue is of prostate and not anything other?
Yeah, because your needle under vision is going in the prostate. So whatever is coming out should be from the prostate. So one of the point I had mentioned is check all the pores. So as soon as you remove, you check whether the core has been there. If it is not from the prostate and it is just rectal mucosa, it will be very thin, flimsy. So if you are suspicious, you can again target and one more biopsy you can take from the
So first
same.
thing you do it under vision, and second the tissue
you see. Every pore you have to check.
Yes. So it is heavier than the other tissue.
Yes.
Solid organ. Prostate metastatic, are there any guidelines for us directly?
What?
Sir, are there any guidelines for advanced advanced and metastatic carcinoma for diagnosis?
No, there are no guidelines. You have to do a transrectal. It is very clear. You see, there are many urologists which I have seen that locally advanced and metastatic के क्या फर्क पड़ता है? Blindly ले लो. But that is not correct. Why are we doing cross-guided biopsies? We want all the needles under vision and avoid complications like bleeding and infection. Even if it is a metastatic severe prostate and you are doing a blind biopsy, you will have a big risk of bleeding. You are not targeting because you are putting your finger and the needle blindly. So there is no question of the stage of the disease in the decision of cross-guided biopsy. So whether it is localized, locally advanced or metastatic, you have to do transrectal guided biopsy only. You should not do blind biopsies. Blind biopsies are dangerous. They can lead to torrential bleeding because you don't know where the needle is going. You are just guiding with the finger and hitting the prostate. So you don't know where it is, where the needle is going. So never ever do a blind biopsy, even if in metastatic severe prostate.
Okay. Thank you, sir.
Thank you, Abhay.
Thank you very much. And sorry again.
Thank you all the delegates, thank you mentors for your valuable discussion. Now there will be a lunch break for half an hour.